Thanks. So yes, it's really a pleasure to present to all of you. I think we're the last presentation of today, right? And I think we are probably the two youngest staff that are presenting to you today. So I don't know if I have my connection that is, can you hear me?
As well, working well.
Yeah,
excellent.
We can hear you. Yeah.
Sorry, I'm in a hotel, so my connection is not great. So yes, we're probably the youngest staff that are presenting to you today. So we're happy to introduce ourselves, but also to speak to you a bit more about how we got into global health and different career opportunities within global health. But of course, we're here mainly to speak about AMR. So at the moment, we're both technical officers, but I did not start working global health in the past. I'm actually trained as a lawyer. I studied trade and investment law and started working in a law firm before I moved on to global health. I was working on trade and investment disputes between countries on the international level, but felt I wanted to do something different. And I rolled into humanitarian affairs at Doctors Without Borders because they needed someone to analyze new refugee treaties and international humanitarian law. And through that, I think there's some Dutch students on the call. I got into touch with Ellen Hoen, who's a Dutch intellectual property lawyer that often writes in the Financial Times. And I became a patent lawyer for MSF within their Access to Medicines campaign, working on all types of medicines and helping countries get access to them, doing negotiations, but also quite legal patent oppositions with actually going to court in many countries. Right now, I'm in antimicrobial resistance. That just occurred quite randomly. I moved to one of the only NGOs that is very actively and solely working on antimicrobial resistance. It's called REACT in Sweden. And with them, I supported their policy work towards the UN, working in Sweden and supporting their office in Ecuador. And after that, I joined WHO as a consultant. And as a consultant, you do certain short tasks for WHO. And I did that for about 2 years. And now I'm a technical officer since, I think, 6 months. So part of the official workforce of antimicrobial resistance. So I've been working on global health for, I think, 4 or 5 years, and with the WHO for two years. And the last year solely on antimicrobial resistance. I think Miriam has a very different path.
Yes, hi everyone. Thanks, Maarten. So yeah, my name is Miriam. I'm originally from Germany, and as Maarten said, I think we are in our AMR division at WHO, we're around 60, 65 people, and there are 3 people under the age of 30, and we are 2 of them. So I also did not really start out in health. I did a bachelor in sociology and then a master in global development, not global health, but global development. So health was part of the curricula, but not extensively. But I was always really interested in health, education, gender. I think that was kind of like my favorite topics. And my first job out of after graduating in late 2018 was at a public affairs consultancy in Brussels, where I actually worked on EU and global health. So this mostly actually, despite being located in Brussels, I worked quite a lot on global health issues, traveled to Geneva a bit in 2019, which obviously stopped in 2020. But this is how I also started working on antimicrobial resistance, because it was one of the projects I was working on back in 2019 and 20. And I don't know if you've heard about this program, but then I applied to the Jpo program. It's a junior professional officer program offered by the UN. It's you apply through your host to your host government. So in my case, Germany. And they publish various positions in the UN agencies, and you need to have around 2-3 years of work experience. So it's usually not possible right after you finish your master's without any prior work experience, but you're all fairly young. And you apply to this program, and I applied to the specific position in the AMR division at WHO. And it's always for 2 years. So I just actually had my 1-year anniversary yesterday. So I entered my 2nd year. And it works a bit differently. Some other countries also then offer a 3rd or 4th year, but it's one of the programs that offers younger people entry into the United Nations organization, because usually it's quite difficult. As Maarten entered as a consultant and then got promoted after a few years working on these short-term contracts to staff, and I got into the UN through this junior professional program. So I think you also have UNVs, United Nations Volunteers, or internships, but I think those are the main entry points of younger people into the UN. So yeah, since a year I'm in the AMR division, and I specifically actually work with 3 other organizations, the Food and Agriculture Organization, the World Organization for Animal Health, and the UN Environment Program, and WHO. They all form the secretariat where they address AMR through all these different dimensions, because as you might know, it's not just an issue in human health, but across sectors. So I'm sitting in the secretariat and coordinating a lot with the other agencies. I think that was it from my side. And I think before we're starting the presentation, because I think you're all global health students, right?
That's right, we're doing public health.
Okay, great. So I think we actually just wanted to start off with 3 little questions just to know what you guys already know about this. So my first question would be, what are antimicrobials? Can anyone tell me? Does anyone have an idea what we mean actually when we say antimicrobials?
I think they all know, because they have the chief medical officer, the old chief medical officer, Sally Davies, has been doing great promotion. So they think this is a too easy question, but maybe someone will step up.
Medications used to treat microorganisms like fungi, but also bacteria and viruses.
Yeah.
So they're resistant to the normal antimicrobial treatments like antibiotics.
Exactly. So we have, 4 big categories. You already said 3. You said we have antibiotics against bacteria, we have antivirals against viral infections, antifungals against fungal infections, and antiparasite medications, which work against parasites. So, for example, malaria. Exactly. And then I already see that some people are writing in the chat. Great. So my next question would have been, what actually is antimicrobial resistance? So one person said bacteria no longer respond to medicines. Exactly. So AMR, short form of antimicrobial resistance. So it also often, a lot of times we also say antibiotic resistance. Those terms sometimes will be used interchangeably. So antibiotic resistance basically really refers to the bacteria, and with the term antimicrobial resistance, we really mean all the categories. So yeah, I see some more answers. So you seem to be well informed. Exactly. So the microorganisms, they develop resistance over time. They no longer respond to medications, and this then leads to infections that are becoming harder to treat. You might get more sick, you stay longer in the hospital, your healthcare costs increase, and you could potentially even die. My last question before we head into the presentation would be, could you maybe say some of the reasons that cause the emergence and the spread of resistance? Feel free to write in the chat or just unmute yourself.
Poor stewardship of antibiotics, particularly in developing countries.
Yeah, I see overuse of antibiotics in the chat, incomplete treatments regime, drug abuse.
Yeah, well, I think, in agriculture, I think the main 4 drivers that, it's not entirely clear what are the main drivers of antimicrobial resistance. And the environment is really increasingly mentioned as one of the core drivers. But currently overuse in humans and in animals is still recognized as the main driver. But what's really coming up in research is also the importance of the spread of infections and the importance of infection prevention and control. And I think that is something that's coming up over the last years. We see that overuse might not be one of the core drivers, or might at least be there on top together with prevention and the spread of infections in healthcare facilities, but also in communities.
Exactly, and I mean, the importance of infection prevention control, I think we all know from the last 2 years, washing our hands, wearing masks, etc. But yeah, so overuse of antimicrobials, also lack of access to just clean water, sanitation, hygiene is also a very big factor that's spreading diseases, and that with it also drug-resistant infections. And it's also important, of course, to know that it's not just spreading from humans to humans, but also animals to humans and vice versa. But great, I think that was the little intro, just with some questions to pick this up. I'm gonna share my screen now with the presentation. Can you all see it okay?
Yeah.
We see the presenter view, Miriam, sorry.
Wow.
But it's okay. But,
it's okay, okay.
Well, we see the notes. Maybe we can go to the other settings.
On my, I have several screens. On my one screen, I see it normally. On the other one, I see it in presenter mode.
I could see it normally, but now it's gone back to like kind of PowerPoint presentation view.
Okay, sorry.
Do you want to share, Maarten, or should I just go along?
Please go ahead. I think, yes, I have so many.
Okay. So yeah, let's kick this off. I think you probably know, everyone knows this guy, especially since the last year. So that's Dr. Tedros. He's the Director General of the World Health Organization. And this is just a little quote he recently made. So yeah, it's also antimicrobial resistance has become a very big priority also of the Director General. And as you can see, I'm not reading out the quote, we can all read it, but yeah, it's really an issue that's cutting across the sector, especially as Maarten just mentioned, also in the environment, food production, animal health, human health. It really, if we don't do anything now, it really will become a very big global public health issue. I don't know if you have seen that there was a recent publication last week or even 2 weeks ago in The Lancet, where there were some new estimates about how many people annually die from drug-resistant infections. I don't know if anyone has seen it. Yeah, so I just see someone said yes. So do you remember what's the number? What slide are you seeing right now?
Now we see it.
It's working now, yeah.
Yeah.
Leading cause of death.
Great. The joy of online working. Yeah, so the Lancet publication, exactly 1.27 million attributable death. Exactly. So that came out last week or the week before. It's actually the first really big comprehensive study on the global burden of AMR. And as rightly said, so 1.27 million deaths were recorded in 2019 as a direct result of drug-resistant infections. And 80% of those were actually just caused by 6 pathogens, which are listed here on the left image. And we also now, for the first time, we got a bit of a better picture where actually the burden is the greatest, because I think previously, because lack of access to antimicrobials was actually always thought is still a very big issue in the developing countries. People just don't have the financial resources to afford medications. So the thought was that maybe AMR would be a bigger issue actually in the developed world. But as we see from this graphic, the highest burdens are actually in sub-Saharan Africa and in South Asia. So I think these numbers have really shown, like, put the whole problem of AMR in a new light, how present the issue is already now. We're not talking about how it will get worse. It is already quite bad.
Yeah, it might be interesting to add that the new disease burden of AMR is really enormous. It's bigger than the disease burden of HIV and malaria. So this also puts AMR in a whole different dimension that we knew of before. We knew the economic impact, but the burden of disease right now is incomparable to what we knew a year ago. Maybe over to you.
Oh, no worries. Also, generally, if anyone wants to ask a question in the chat or something, just please interrupt. We can make this quite easygoing. Yeah, as Maarten just said, the economic impact, there was a model from the World Bank a few years ago. So, which, as you see here on the image, economic cost of AMR by 2050 could become comparable to the 2008-9 financial crisis if we don't do anything now. So I think this is also quite a staggering number. You've all probably heard about the Sustainable Development Goals, which, of course, the work of the UN agencies is centered around, and we have SDG 3 is focusing on global health and well-being. But given that AMR is affecting, is caused by and contributes to so many other areas, it's really not limited to working in SDG 3. So it really is affecting several SDGs across the board. We got a new indicator approved, which is measuring the level of the proportion of patients which have bloodstream infections. So this is just a bit of a background on the SDGs. We've already talked a bit about the drivers of antimicrobial resistance. This is a nice image from also, I think, a report from 2019, which shows this is affecting all areas of life. So we already said misuse, overuse of antimicrobials from humans is driving antimicrobial resistance, but also mis and overuse of antimicrobials in farm animals, lack of access to clean water, poor infection prevention in health care facilities, in farms. They all contribute. And Maarten also made the very important point that the environment and the spread of drug-resistant infection through the environment is becoming more and more important. And the next slides are just a bit showing what, I mean, I've probably a lot of you have already also traveled in the global south, but it's very common that we see these pharmacies on local markets. We have very overcrowded hospitals, healthcare facilities, quite bad hygiene, let it be in restaurants, in hospitals. So this is all breeding grounds for infections and drug-resistant infections to spread. Equally, in animal health, of course, in the EU, there are quite stringent regulations on how many animals you're supposed to have on so-and-so kind of square meters, etc. But in other parts of the world, it's animals are held in massive cages, and the hygiene, the lack of hygiene is enormous. So they get sick, easily transmitted to other animals. So this is just a bit to visualize it. I see some things in the chat. Okay, it's the Lancet article. Great, thank you. And as Maarten said before, we also now in the last 2 years, we've been working closer and closer together with the UN Environment Program, because there's now increasing evidence that the environment plays a very crucial role, especially in the development and the transmission of AMR. So the unit I'm working in, we used to work in the last few years only with the Food and Agriculture Organization and the World Organization for Animal Health. But now, as of January, as of last month, the UN Environment Program officially joined the three organizations in working on AMR. So this is quite a milestone that the UN Environment now also is on board and working quite closely together with all of us. I am handing over to Maarten now for the next part of the presentation, which goes a bit more into the details of what we're actually doing at WHO. Over to you.
Thanks, Miriam. I think, yeah, so antimicrobials, antibiotics specifically, they were introduced to the world after the Second World War. And already in the Nobel speech of Fleming, he warned of the threat of antimicrobial resistance. But for a very long time, antibiotic resistance, it was on the agenda. It has been discussed in various expert groups and fora, but it didn't really get any attention. And the feeling was that, you know, we were in a time where there were a lot of new antibiotics that were developed, and this would be solved by R&D, or it wouldn't get as bad as we would expect. And I think around the year 2000, real action antimicrobials started. On the UN level, it started for a long time, but the first real global plan was the Global Action Plan on Antimicrobial Resistance. And what is special about antimicrobial resistance, as Miriam just showed, is that we have to work together with many other different sectors, the agricultural sector, veterinarians as a profession, environment. And because of that, we have to have a global plan in which we lay out the type of work that we do. So through this, by the World Health Assembly in 2015, the Global Action Plan on Antimicrobial Resistance was created. It was adopted by the World Health Organization then, but later adopted by the Food and Agriculture Organization and the OIE. The OIE is a multilateral organization that works on animal health. And these 5 strategic objectives that I'll speak about more were developed that are kind of cross-sectoral. And based on this global action plan, countries have started to also implement national action plans. And this is unique because before 2015, you could go to many countries and they would have never heard about antimicrobial resistance or antibiotic resistance as a public health issue. And right now, as of January 2022, 148 countries have finalized their national action plans. But we are still stuck in an issue where there's no funding for AMR. And part of the reason for that was the burden of disease data. Burden of disease data is not directly correlated with funding, but it's usually important to show that funding to a disease is necessary. So what we see is that many countries are still looking for funding, and this is why the Lancet paper right now is extremely important for us for advocacy. Next slide, please. Yeah, so the first point that we work on is awareness, education, and behavioral change. And one of the key areas is the World Antimicrobial Awareness Week between 18 and 24 November every year. Through the World Antimicrobial Awareness Week, we engage all countries and hospitals and national societies to, during this week, organize some lectures, some workshops, and to raise the issue of antimicrobial resistance on the national level. And for this, the WHO works together very closely as one with all the regional organizations of the WHO and all the country offices. So every year we have different focus and we have different groups that we target. Next slide, please. The objective 2 is surveillance and research. And as we said, the disease burden data was not there. And that is because antimicrobial resistance is such a large issue. There are so many drug-bug combinations that you have to look at in order to get a global picture of the spread and the magnitude of antimicrobial resistance. In order to have a common system, in order to collect data, we have the Global Antimicrobial Resistance Surveillance System at WHO. Currently, it aggregates data from 64,000 surveillance sites with more than 2 million patients from 66 countries. And it does that not only of antimicrobial resistance, but also antimicrobial consumption. So we can have a global picture of the status of AMR. But since many countries are involved, but we still have an enormous data gap between northern countries that have been working on antimicrobial resistance for quite a long time and the southern countries that are starting up, but also still need a lot of capacity building in their laboratories and surveillance systems. Next, please. And I think the two core areas that we work on are optimizing the use of antimicrobials, so reducing the driver regarding use, and infection prevention and control, so reducing the driver regarding spread. For optimizing the use of antimicrobials, the focus has long been on healthcare professionals, but right now we're really trying to engage everybody. And one of the tools that we have, I don't know if you've heard of the essential medicines list of WHO, but WHO provides a list of the medicines that are key for a country to have access to. As part of the essential medicines list, we now have the, I think since a year or 5-6, we have the access but reserve aware categorization. And that is a categorization that helps country in deciding which drugs everybody should have relatively easy access to, which antibiotics should be on watch and should be used in limited situations, and the reserve antibiotics that only should be used when all antibiotics have failed. For the rest, of course, we're focusing a lot on IPC. And I think, as Miriam said, water and sanitation is one of the core issues. And it's also an area that relatively is not so much discussed in global health, but we're still in a situation in which more than half of all the hospitals or half of all the healthcare facilities, in the world do lack access to clean water. And this, of course, you can do a lot of hand washing campaigns, but the structural issues around IPC are enormous. That is something that needs proper addressment, and something we are collaborating on with antimicrobial resistance. Next slide, please. Yeah, my project that I'm working on mainly is about legislation and antimicrobial resistance. As you might know, in many countries, and I think this is really something that has changed over the last 20 years, antimicrobials were always available over the counter, and they were available in very strange fashions, very often as fixed dose combinations together with other flu medicines. Antimicrobials were really a commodity that was sold in bulk. It was sold as much as possible. And I think in the UK, the discussion started in the 90s and they had a commission. But in many countries, it's still an open question what to do with the over-the-counter availability of antimicrobials. And this is the same in the animal sector. So we're working on providing countries with legislative support. We did the International Instruments Report, and now we're providing support to Zimbabwe, Morocco over the next year in evaluating their legislation for antimicrobial resistance on this use, but also on infection prevention and control, on the accreditation of doctors and pharmacists, and how to sell antibiotics and other antimicrobials in an optimal way. Next, please. The last objective of the Global Action Plan is R&D. And as I said in the beginning, we had, since the 1940s, we had years where lots of new antibiotics were discovered. And since the 1980s and 2000 later, we got into a situation where there's just no R&D anymore for antibiotics. And this has many causes. This is still open discussion. I think most of the antibiotics now have been discovered. But on the other hand, the interest for antibiotics in the pharmaceutical industry became less, and there's much less relative return on investment around antibiotics. Companies much rather would invest in non-communicable diseases in which they could make a profit for a very long time than antibiotics that have the risk of becoming resistant, that are often used only once by a patient. And what we saw, I think, in the AMR industry report that came out yesterday, is that the total investment last year for antibiotics was 1.9 billion, while the average cost of a new treatment, it's very much a rough estimate, would be 2 billion. So we're really not in a commercial environment in which antibiotics will be developed in the future unless we do something. And what the solution is for that is a major discussion. Next slide. So what WHO is doing for this, it's looking at the R&D pipeline. It's creating priority pathogens list to inform commercial players what would be the most important pathogens to look at for commercial industry. And then we're following the preclinical and clinical antibacterial pipeline. I think you've all seen that fungal disease and fungal resistance was a really important topic during COVID, in which there was an outbreak, but also in R&D, fungal disease has been absolutely neglected. So since this year, we're also looking at what is in the antifungal pipeline. And this year, some new antifungal drugs were added to the essential medicines list, because the treatment of fungal diseases is really something that has not been discussed outside of HIV for a long time in global health as a general topic. We're also creating target product profiles. Target product profiles also inform industry what would be the circumstances in which the product will be used and how the product should be developed around that. And we're setting up new initiatives. One is GARD-P, which was set up together with DNDi. The DNDi is the Drugs for Neglected Diseases initiative, and they create new drugs for neglected diseases. And together with them, WHO set up GARD-P, which is the Global Antibiotic R&D Partnership that is developing new drugs with a focus on the global public health priorities. And one of my core pieces of work at the moment is the setting up of Secure. Secure, next slide please, is a new partnership that we are creating with UNICEF, CHAI, and GARD-P that focuses on the lack of access to antibiotics. And what we see with the current global burden of disease is that much of this is also caused by a lack of access to antibiotics. Antibiotics are still drugs that are most in stockouts and in shortage in countries. And they're also the drugs, together with malarials, antibiotics, together with malarials, are the drugs most found to be substandard and falsified. What this means, of course, is a very poor patient outcome for patients that should have a chance to survive a simple or relatively simple infection. But this also leads to situations in which physicians often prescribe more antibiotics than necessary, or more broad spectrum antibiotics than necessary, leading to resistance. There's also a lack of access to these new antibiotics. There's not many that come to the market, but of the 80 new antibacterials that came to the market between 2010 and 2019, most of them are not even available in high-income countries. You can see that the UK is doing quite well, but together with the US and Sweden, all these countries have special programs to incentivize market access, but all other countries in the world basically do not have access to the antibiotics that have been developed over the last 10, 20 years. Next slide, please. Yeah, so together with these partners, we're developing a new facility. We all know the TB drug facility, perhaps. This is something that we're recreating for antibiotics, but in a way that, of course, includes stewardship and the clinical needs of antibiotics. So I'm happy to answer any questions on that, it's a very exciting new project. Of course, this requires a lot of funding. And I think this is where the WHO really shines. In WHO, we have a lot of outreach to different partners in all the different countries in the world. So we're currently engaging with the G7 that is now led by Germany to see which countries will be engaged in this project. Next slide, please. This is it. Thank you so much. I think it's interesting to say, you know, Miriam and I, we both have a policy background, but if you look at the division, it's quite interesting to see that, you know, we work with a lot of scientists, and it's I think the division between doctors, scientists, other scientists and doctors, and policy experts coming from different areas is around 30%, more or less, like 1/3 doctors, 1/3 other scientific experts, 1/3 perhaps policy experts. So there's a huge collaboration between all types of expertise within the WHO, and it's great to work on all these projects in that.
I think we have a first question in the chat. How has COVID-19 contributed to the burden of AMR? I can give it a start, and then Maarten, I'm sure you can contribute. I think it's pretty mixed. So of course, in a sense, because we have been better at hand hygiene, wearing masks, probably also even facilities, they're better at cleaning, we're keeping our distance. So all of that certainly has contributed that. I mean, I have not been sick in 2 years because of all these measures we've been taking to be more hygienic. So that has certainly reduced the spread of potentially drug-resistant infections. And then on the other hand, especially in the beginning, we didn't really know what worked against COVID. Of course, it's caused by a virus, so you shouldn't antibiotics, but it's often people also develop bacterial co-infections, so they were then prescribed antibiotics. So there might be in certain places definitely again a mis or overuse of antibiotics because people just wanted to take anything that worked. So I think it's still quite a mixed picture. I think a few first studies might be emerging. Maarten, do you want to please add to it?
Yeah, no, you covered it well. I mean, I think, you know, all disease areas have hugely suffered from COVID, and the progress that we've made is also limited by not being able to engage with countries on the ground. And of course, everybody that we engaged with in Ministries of Health was busy with COVID over the last years. And we only see now over the last months that it becomes easier to pick up the on-the-ground work on antimicrobial resistance. And then the first studies are coming in that show the extreme overuse of antibiotics that has occurred during COVID-19. And this is not something that, you know, it happened, of course, in countries where there's a lot of over-the-counter sales of antibiotics. There's even some countries that have banned online sales and over-the-counter sales during COVID-19 because they saw so much misuse of medicines. But it is also something that has occurred in all the, I mean, even in Switzerland, in the Netherlands, hospitals started to prescribe anything at some point to treat COVID-19 patients. So, you know, right now, the real public health impact, it's something we cannot assess because it's so complex to look at AMR as a whole. But it's safe to say that the impact will have been big. We're looking forward to these studies.
Yeah, and I think this is the direct impact on AMR and then potentially antimicrobial use. But as Maarten briefly touched upon, the impact that COVID has on other disease areas. I think it's the latest TB report on tuberculosis showed that for the first time, and also malaria for the first time in decades, they actually recorded again higher numbers of death and infections because of the lockdowns and people delaying treatment or being later diagnosed. I think we will only now see in the next few years really what the impact has been on AMR and other diseases.
Drivers of resistance is a really good question. You know, there's so many studies. We always point at the same one because it's the only one that we really have for global drivers, and that shows that use of antimicrobials in humans is the main driver, and shortly after comes antimicrobial use in animals. I recently saw a European study in which they saw a spread of antimicrobial resistance as the main driver in the EU, and that it was mainly caused by the cross-border healthcare and the placement of patients across borders that showed that resistance is really spreading between countries in a very fast way within the EU. And I think, as Roger pointed out, it really depends on the country situation. I think some countries have a really major risk in their agriculture. Coming from the Netherlands, you know, I think countries with a lot of agriculture have a major risk of AMR. In the Netherlands, everybody that works in agriculture has to be quarantined when they go to hospital for a reason. You know, the comment that agriculture in Kampala might have a negative impact on Manchester is of course true in the very long term. And we see these studies about international travel and people bringing home antibiotic resistance in their bodies through travel as well. Of course, it's very difficult to say, right? It's those type of international the type of international spread of resistance is something that is I mean, they found antimicrobial resistance in hedgehogs recently, which they expected to come from human use. It's very difficult to say what is causing certain resistance. And it's also difficult you don't want to blame certain countries that you know, countries like countries in sub-Saharan Africa generally are the countries that use much less antibiotics than they probably should use compared to all other regions in the world. So it's very difficult to point at a certain region or area as driving resistance.
I think I also, it's been a few months, but I saw a very interesting study. I think it was done in Namibia on school children, like ages 6 to 10 or something like that, who had never actually taken antibiotics in their life, but they still found strains of drug resistance microorganisms in their bodies, which I think, so they never even used antibiotics in their life, but you could still find it. So it's mis and overuse. I think, as Maarten said in the very beginning, it's one of the main drivers, but we're learning more and more now what other big drivers contribute as well. So we cannot just look at this one driver. I think there was a question from Tim. Have you done any work on how to influence the behavior of prescribers so that they access educational resources on best practices?
Yeah, it's a good question. You know, I think it's quite interesting that when we speak about behavioral change, we always speak about education as the first tool for driving behavioral change. Well, if you look at behavioral change research, you see that, for instance, in the behavioral change pyramid that the US CDC often uses, I think the old director created that. You see that education is one of the, it's one of the least easy forms to drive behavioral change, because it's the prescribers that are prescribing right now, in many countries, their follow-up education is maybe once per year. They have a lot of things to cover on the clinical practice. So it's not so easy to have education as a quick solution. I mean, education of students like you on antimicrobial resistance, that is absolutely key, and it has a much more quick and impact that will help you in your career as a medical doctor or whatever path you choose. For behavioral change, we're looking at many different aspects. And I think the work that I'm doing on regulation, for instance, and new legislation in countries is also a very long-term approach, but it's also something that drives behavioral change. We're looking at ways to include antimicrobial resistance in education, also of primary school students and secondary school students on the national level. And what we're mainly looking at, of course, is data-informed decision-making on the hospital level, how to set up stewardship mechanisms within the hospital and discussions, how to track use, and how to really hold people accountable as well for the use of antimicrobials that they are doing. And I think in many countries now, doctors are actually actively get feedback on the antibiotics that they prescribe. In Switzerland, they send letters to doctors that are in the top 20% of antimicrobial use, just to make them aware. And this type of combination of nudging and database approach is something that we see is working really well. But of course, combination of all tools for behavioral changes is essential.
Yeah, this, I think you mentioned programs for children. So UNICEF is actually doing quite a bit of work on how to educate children on antibiotic use. They have a small AMR team, but they're slowly getting more and more work on this done, which is quite nice. I think the next one was, how can we increase investment in R&D for AMR when it's considered a relatively high risk investment? Yeah, it's so difficult to answer that. We've been calling in R&D, we always speak about push and pull incentives. And the push incentives are the investments that you do up front through funding research. And I think that has really made a lot of progress over the last decades. There's a lot more researchers that are interested in AMR. What we do see is that many people that specialize in AMR are now, all the experts from the past, they've moved on to other disease areas, and new PhD students, they often are kind of reluctant to move into antibiotic resistance because the career perspectives are just not so strong. And that really makes it very difficult. And at some point, these push incentives are really not enough. So right now we're looking at pull incentives, and pull incentives are just basically paying more for the antibiotics that you have. But we all, I think we all understand that these types of incentives with the pharmaceutical industry, they have to be done very carefully.
in a way that really benefits public health, because otherwise you're wasting billions. And industry, of course, is very interested as well in these types of incentives. So it needs to be guided by strong control of government and also strong prioritization of public health needs. So we're looking at different ways, and right now we have a new Netflix model that many countries are using, in which countries are not paying for the amount of antibiotics, but delinking the price from the number of antibiotics that they're using. And this could, for very little antibiotics, they're just paying quite a bit more unless resistance is increasing. So these type of new contracts that have also been used in hepatitis C is one of the solutions that's being proposed. And this is something that the G7 is also now discussing.
I think also, for example, one mechanism that was set up in 2020 is the Amr Action Fund, which was developed by the World Health Organization, the European Investment Bank, and the Wellcome Trust. And their goal is to bring 2 to 4 new antibiotics to the market by 2030, I think, and to collect and invest more than 1 billion. So they are several big pharma companies are investors of this fund to really catalyze and support actually smaller, medium-sized enterprises to do antibiotic research and then not to go bankrupt, as we have heard in the past as well, where smaller pharmaceutical companies actually developed antibiotics, but then they went bankrupt because they don't make any revenue with these old traditional models. So the Amr Action Fund is really trying to support them and bring antibiotics to the market. So this is for example, one of the mechanisms that was set up recently to try to catalyze R&D.
Yeah, I see one more question about the major vulnerable groups with respect to AMR, and what are the target policies and programs that are underway in WHO? This is a really good question. And I think this is also something that, since AMR is such a new disease area, it is not focusing so much yet on the major vulnerable groups, and we don't have the data yet because the segregation in the AMR data is not there yet. The data collection is so complex already that we're now only expanding on getting that data ready. WHO did some studies. I think it looked at gender sex and gender as a driver of antimicrobial resistance. We see that women suffer more from antimicrobial resistance. It's a major risk to the successful performance of C-sections, etc. One of the other main identified groups is neonates. Newborn children are extremely vulnerable to infection, to neonatal sepsis, and I think they are one of the main groups that is suffering, and that has also been identified in the burden of disease study of the Lancet. And what is interesting to see is that the lack of antibiotics or the lack of quality antibiotics is a major driver. I think, now I don't have the numbers ready, but I think around 10 to 15% of neonates dying from neonatal sepsis is dying because they don't have access to proper quality drugs. So they are using the drugs, but they have such low substandard or falsified quality that the treatment is not working. So there's different areas to focus on in that. Another vulnerable group is MSM, men who have sex with men. And I think drug-resistant gonorrhea has been identified as a major concern.
Yeah, I think so. There was when you mentioned gender, WHO published a working paper on the relation of gender and AMR a few years ago, and this topic is gaining more recognition at the moment. So Fleming Fund, the massive UK aid program, which is focusing on AMR, they just kicked off a new work stream also on gender and AMR, looking in because it's, for example, women do a lot of the child caring, women do a lot of the how do you say that? The lighter farm work, for example. Men maybe deal more with the big cattle, but women do a lot of the farming and herding the smaller animals, stuff like that. So certainly women are more exposed, but then, as Maarten said, you have men having sex with men who are exposed. So it's different in different situations, different genders, age groups are at different levels of risk, but there's some work is being done around this now. I still think it will take a few years to have proper data on it, but it's among the upcoming work that I think we really want to do.
Yeah, and one of the areas that has been, I think, quite under-researched, of course, is co-infection. I mean, people that are already suffering from other infections very often also suffer from antimicrobial resistance. Is something that we have identified with fungal infections in HIV patients, but co-infection and antibiotic resistance as a whole, it needs a lot more research. Could be an interesting topic to look into. There's many questions that I haven't been able to look.
I think the next one is, if I skipped one now, apologies. How do we approach reaching a global consensus for action when the barriers are so different across countries?
It's a really good question. There's so many different interests between countries. You know, countries with a huge agricultural sector, they will say, let's start with the human use. All countries with a very strong private healthcare systems will have all the hospitals and doctors say, let's focus on the farmers first. There's a lot of interest around antibiotics and antibiotic use and antibiotic sales. There's also an interest from governments sometimes in antibiotic access to antibiotics as an easy solution, an alternative to providing proper primary healthcare. And the challenge is just enormous. I think there's so many factors that you need to look at for antibiotic resistance that real global consensus is very difficult to reach. Right now, what we see with COVID-19 is that we have this pandemic treaty that's being discussed, and antibiotic resistance is also being discussed within that treaty. But as you know, the discussions around the treaty are complex, and in any infectious disease and infectious disease prevention, the interests are so diverging that it's complex. In antimicrobial resistance, it might well be even more complex. What we do see is that there's real progress on the regional level. And I think in the EU, we see real progress, but also in many other regions, we see that antimicrobial resistance is increasingly taken up. And on the regional level, there's much more common interest most of the time.
I think it's also important to remember that countries are at very different levels of development. So very, very low, least developed countries, also potentially war-torn, conflict-prone countries. Their development priorities are really likely not on AMR in this instance. Countries, I work in it's called AMR Multi-Partner Trust Fund, where we're supporting 11 countries. One of those countries is Sudan, where they were approved for funding, but now with the recent coup, all the funding got suspended again, so the program was halted. So I think this is also to remember countries at very low levels of development, their priorities are often on the bigger global health issues like maternal mortality, let it be if they have insane rates of HIV, stuff like that. But yeah, I think finding a global consensus it's incredibly difficult.
Yeah, and the work in global health really follows the funding, right? And the funding of AMR, you can look at the IHME analysis of the funding. You will see the big graph with the funding per disease. You will see that AMR is almost not visible at the moment.
Even health is still quite underfunded generally.
Yes.
Within health, AMR gets a teeny tiny amount. So as Maarten said in his presentation, all these countries, 148 countries have now national action plans on AMR, which look great on paper, but they're all not funded. So nothing can move. So yeah, it's a big issue.
Question MRSA, I'm not entirely sure. I know that many countries are taking different measures for MRSA, but also I know that the high-income countries are taking indeed screening patients for other infections as well, especially on intensive care. But I'm not entirely sure about that.
Tests for other infections here. I work in a hospital.
Thanks, Penny. You're the expert.
Does anyone have any more questions they want to put into the chat or say off mute?
I have one question.
Please go ahead.
I was just wondering, like, in a kind of long-term plan, like, is the long-term goal to kind of just manage this by the WHO until new antibiotics can be developed that, you know, are going forward are better, or what is the end game?
It's a really good question. I don't think we really focus on an end game for antimicrobial resistance, just because it's, you know, it's like in so many discussions. Some people, they really focus on R&D, and they think that R&D will perhaps provide the solution in the next 100 years. And then we will have worked on this in many ways, but it's like climate change, right? That's also the case. Maybe we will get saved by R&D, and we will find some solution through that. But that's not really the end game that we're fully aiming for or betting on. And it would not be evidence-based if we would do that.
Yeah.
So right now, I mean, the end game is to be able to strengthen healthcare so much, and to optimize the use of antimicrobials so much that we at least keep antibiotic or antimicrobial resistance to a minimum. But it's, I think, an end game with AMR at the moment. In the stage that we're more in a crisis stage in which we try to mitigate. And this is also the language about AMR. There's so little funding, there's so much work to do. It's really about strong healthcare systems, access to diagnostics, access to primary healthcare, simple infection prevention and control, and basic access to facilities in hospitals. All the basics of universal health coverage are of great importance to AMR, and the end game for that is really not visible without increased financing of healthcare. And that's, yeah, so the eyes are not in the end game, I think, at the moment.
I think also if you compare it with HIV, I mean, now 3-4 decades later, we have well-functioning drugs, but they are also expensive. Your infection needs to be diagnosed. If you don't have primarily healthcare system set up that in the first place diagnose you, or people even first need the trust to seek healthcare and healthcare professionals. So I think it's a massive undertaking. So I think what we at WHO now lately trying to do, we really want to shift also this narrative. As Maarten said, we are a bit in a crisis actually. So often, I don't know if you've seen it, always called AMR the silent pandemic. It's often flying around, but we really want actually to move away from this term, the silent pandemic, because it's not silent, it's right there, it's in front of our eyes. So I think, the end game, I mean, in an idealistic world, it would be great if everyone could seek healthcare and would get treated, but I think that's a bit utopic. So yeah, it's a massive undertaking.
Thank you.
Thanks, Penny. It's a good question. I think we're ending off perhaps with.
But I think, yes, sorry, someone was saying something.
No, I was just wanting to ask if anyone had any more questions that they'd like to share.
Thanks so much for your participation. All the really, really, really good questions. I think if you have any questions about WHO or about AMR or anything, please feel free to reach out to us or here on email or social media. And yeah, pleasure. I hope you enjoyed it. I don't know if you have more days with WHO. Let's enjoy with the colleagues if you still have some more presentations. And thank you very much.
Yes, thank you very much. And yeah, best of luck with your studies.
No, thank you, Maarten, for your time and a really interesting discussion on AMR. You know, it's been really insightful looking at the barriers from different perspectives, and I'm sure we've all really enjoyed it and found it very helpful.
Thank you. Have a super nice rest of the day.
You too. And
bye.
This is our last session of the day. So I just wanted to say thank you to all of you for joining and spending your time with us. You know, thank you to Doreen and Greg for coordinating and putting together a really wonderful and varied 2 days of webinars. And we've covered a lot of multiple important topics and issues. So thank you to all of you. Hope you have a good rest of your day.